Welcome to this postgraduate lecture series as part of the Medi Classes initiative in which we try to cover the entirety of pediatric endocrinology over the 36 modules covering different aspects. And we have been covering electrolytes for the last few months. We already covered hypo and hypernatremia as well as hypokalemia. So today we're going to finish off the electrolyte module using the module on hyperkalemia. Now, hyperkalemia is a scenario which is usually an acute emergency and we don't encounter in terms of chronic causes, but that can have huge implications in terms of evaluation and management. So we had this 1-month-old child who presented with reduced feeding, and this child had not gained weight at all in that perspective, and investigation showed hyponatremia and hyperkalemia. So usually we talk about sodium and potassium being linked. And when we discuss electrolyte, we said that whenever your sodium goes down, generally the potassium goes up. When your sodium goes up, the potassium goes down. So this is again going a situation where the sodium is low, potassium is high, suggesting that there is a problem in the renin, angiotensin, aldosterone system. Now, further workup, of course, the first thing you will consider in a child would be to exclude congenital adrenal hyperplasia or adrenal hypoplasia congenita. 17-hydroxyprogesterone and cortisol levels were both normal. Now, if we go further our algorithm, we found that PRA and aldosterone levels were high. So we had a child who had a high aldosterone and despite that had hyponatremia and hyperkalemia, indicating that we are dealing with an aldosterone resistant state. So this led to the diagnosis of quote-unquote pseudo-hypoaldosteronism. But here comes a catch. So whenever you're making a diagnosis which is rare, you have to think of other possibilities. And we'll discuss subsequently that a pseudo-hypoaldosteronism-like state can be induced via infection and obstruction. So this actually happened to be a UTI in the setting of obstructive uropathy, which resulted in a transient aldosterone resistance, and that caused this scenario. So whenever you're diagnosing these scenarios, think about obstruction and infection, which becomes important in that regards. Now, this is the format which we'll follow. We'll start off a bit about pathophysiology of hyperkalemia. Then we'll move forward towards criteria and etiology with Dr. Vibha. We'll be discussing about, then I'll touch base about assessment and management. And finally, we'll have a quick, interesting scenarios and question answer sessions which Dr. Manoj will take forward. So all of you can participate in that using the chat option subsequently. We'll also be taking the questions at the end of it in that perspective. You all can go and have a look at our website, learning.growsociety.in, where there are a lot of resources with regards to pediatric endocrinology, besides a number of courses and our e-learning portal in the YouTube channel, and the various courses which are available, including fellowship programs, diploma programs, and we have an exclusive course for postgraduates which covers all these modules over a 3-year period, specifically for pediatric postgraduates in that perspective. You can also follow our grand rounds, which are more in a pediatric endocrine perspective, symposiums which happen regularly, in this PG lecture series, which we plan over the next 3 years to complete the entirety of pediatric endocrinology. You can also have a look at our multiple publications, which are there also in the form of physical as well as virtual platforms and a mobile application.
A 13-year boy who presented with the diabetic ketoacidosis. Patient has a pH 6.9, which is a severe acidosis. Serum sodium is 128 millimole per liter, and potassium is 3 millimole per liter. So now, this child have severe diabetic ketoacidosis. So my first question is, what are the usual sodium common electrolyte abnormality that we generally see in the DK? So this answer you can write into the chat box.
So what do you expect in terms of sodium, whether you have a true sodium deficit, and along with that, whether you assess it normally or exaggerate that, and then what happens to potassium, whether you have hypo or hyperkalemia. So I think these are the key things to look at from that perspective. Yeah.
So, yeah.
So yeah, carry on. Yeah.
Yeah. So there are the hyponatremia and hypokalemia is common abnormality that we generally see in the DK. Hyponatremia is due to the dilutional hyponatremia, and we see the generally false picture of the potassium. Actually, due to the cellular shift or insulin deficiency and due to the acidosis, potassium come from the cell. So actually, potassium is low in the blood. But because of the cellular shift, we are seeing whatever potassium we are seeing, it is actually falsely elevated. So on the potassium perspective, there is the hypokalemia that it occurs due to the cellular shift. So, and my second
You have
question is,
got hyponatremia, which you are exaggerated because of the sodium dilution, and then you have got hypokalemia, which is masked by potassium shift. Now, the next question, Dr. Manoj.
yeah. The second question is, what is the actual potassium in this case?
So you can
So
write
as
on the
we have
chat box.
discussed, yeah, as we have discussed that we are seeing falsely elevated potassium into the blood. So what would be the actual potassium in this case?
So what is the potassium? Has anybody written on the chat box? Not yet. So we can continue. So we know that for every 0.1, how much does it increase, Dr. Manoj?
So every 0.1 decrease in the pH increase 0.6 millimole per liter cellular shift of the potassium. So that means in this case, pH is 6.9. So normal pH is 7.4. So there is a deficit of 0.5 of pH. So if we multiply with the 0.6, then the potassium loss from the body is 3 millimole per liter. So in the HUL total potassium will be nil in this patient.
So if you have hypokalemia with this severity of acidosis, I'll be very, very careful in that regards. Even starting with the fluid, I have to give potassium, and also importantly, never start insulin in this scenario unless the potassium is built up. So this is a severe scenario in that regards. So I think this question again, Dr. Manoj.
Yeah. So my third question is, what causes falsely elevated potassium in the diabetic ketoacidosis? So as we previously discussed,
carry on.
Yeah. So as we previously discussed, there is an insulin deficiency in the diabetic ketoacidosis, which moves potassium from cell to the blood. And secondary thing, acidosis also drags the potassium from the cell. So these two mechanisms cause falsely elevated potassium in the diabetic ketoacidosis.
So basically, insulin deficiency and acidosis is causing the problem. So what other mechanism can cause false elevation, Dr. Manoj?
Yeah. So the other mechanism, as we discussed previously, that other mechanism is like acidosis. If we are giving some beta blockers, or due to the tumor lysis or tumor lysis or cell lysis or thrombocytosis like picture, can cause falsely elevation of the potassium in the blood. It is mainly due to the cellular shift. So these are the mechanisms that cause falsely elevation of potassium.
Sure. So we'll move forward to the next case.
So the next case is 4-year-old boy presented with the red urine with increased CPK in the blood and diagnosed with the rhabdomyolysis with the potassium of 6.2 millimole per liter. So basically, this patient has the rhabdomyolysis, and due to this reason, for potassium, there is the hyperkalemia, which is the 6.2. So now my first question is, what will be the incorrect associated biochemical picture for this case scenario? First option is hyperphosphatemia. Second is hypermagnesemia. Third is hyperkalemia. Fourth is hypocalcemia. So among the four, which one is incorrect?
So I think this is an interesting question, and Vibha had discussed it a lot as well. So you can put on the Q&A or the chat, where Q&A if you can answer, or the chat you can answer the questions. I'll encourage all of you to write. So whether you will have hyperphosphatemia, hypermagnesemia, hypercalcemia, and hypocalcemia. Now, this question is such that only C or D can be correct, because you can either have hyper or hypocalcemia. So Manoj, you can go ahead.
Yeah, so basically, in the case of the tumor lysis, we generally see hyperphosphatemia, hypermagnesemia, and hyperkalemia. These pictures are associated because of the cell lysis. There is a movement of the intracellular ion into the blood, but we generally don't find hypercalcemia because this phosphate bind with the calcium and it decrease the calcium level. So with the tumor lysis, there is the picture of the hypocalcemia, not a hypercalcemia.
So this has been answered correctly by Dr. Muthu, who said hypercalcemia.
Yeah.
What are the symptoms of hypercalcemia? I think Dr. Manoj, we have already discussed this, so you can just quickly go through.
Yeah. So what are the symptoms of the hyperkalemia? So basically, hyperkalemia don't present with any acute system. If the
So I think there seems to be a bit of an issue. So hyperkalemia generally is not really associated with symptoms. Often you will have symptoms which are very late, like paralysis, or you have got ascending paralysis and cardiac abnormalities. It's mainly the ECG changes that we are looking at in terms of the symptoms which are there. So we will move forward to the next scenario. So now the next question is, at what level of hyperkalemia do we get the ECG changes? So I think this we have discussed, that if your levels are typically going beyond 5.5, you will start having a problem in terms of the issues which are there with regards to the peak T waves which are happening. If it goes beyond 6.5, you have got the QRS complex which starts to widen. Sine wave will happen on 6.5 to 7, which we have discussed earlier in that regards. So if we just summarize, and this is what is again we discussed earlier, that depending upon the levels, you will have the peak T wave. 6, you will have widening of PR interval and QRS duration. And then you will have a sinusoidal wave around 8, which will be a very, very terminal thing. Remember, the key figures are anything above 7, you have to treat. 6 to 7 with rate of rise that you're expecting, you will need to treat again in that perspective. Now, next question is 1-month-old girl presented with dehydration, hyponatremia, and hyperkalemia. On examination, there is normal genitalia and no pigmentation. So you have a girl who has a normal genitalia, 17 OHP is normal, and aldosterone is high. So you can quickly think about what we had discussed earlier with regards to neonatal salt wasting. What is the most likely diagnosis? So maybe we can have quick answers on the Q&A. Anybody can put in. You have a girl who presents to us with dehydration, who has got a hyperkalemia, normal genitalia. What do you think is the cause that we are looking at? Anybody? So as discussed, if a girl has a normal genitalia, it cannot be 21 hydroxylase deficiency. And you have got a high aldosterone, so we are most likely dealing with a pseudo-hypoaldosteronism in that scenario. Now, what investigation? So again, Dr. Rajesh has mentioned PHA. Dr. Muthu also has mentioned pseudo-hypoaldosteronism as a cause. Now, the next question is, what investigation is a must in this patient for diagnosis? So before you label as PHA, anything else you would like to do in a simple level to exclude a possibility? Anybody? So you can also put on the chat box, you are diagnosing PHA. So you should definitely get an ultrasound done and a urine routine microscopy. Dr. Muthu again has mentioned that. So he's quite quick in terms of these aspects. Next issue is, what are the inheritance of type 1A pseudohypoaldosteronism? So we can carry forward. So inheritance, we discussed there are 2 forms of PHA. PHA 1A, which is severe, and PHA 1B or 2, which is basically mild. So usually if you have a severe disease, you will have a different modification. So you usually have a recessive form in that regards. Next question is, what treatment will you like to give in this scenario? So we can ask people to put up the treatment. So you can put out the key treatment that we can give in this scenario. So essentially what you're looking at is that you have a deficiency of effect of aldosterone. You give a very high dose of aldosterone, which will counter the effect. You give a lot of salt. You give a lot of bicarbonate, and that will give you the picture in that perspective, and that will help you out in terms of reaching that aspect. Now, next case, Dr. Manoj, I think, is there.
Yeah, so sorry, it was some technical error from my side. Yeah, so 5-year-old boy presented with the potassium 5.5 millimole per liter, and the BP is higher side. BP is 122 and 82 mm per Hg. And surprisingly, generally we see if there is a hyperkalemia, then we generally notice about the hypokalemia. But in this patient, sodium was around 145 millimole per liter. So my first question is, what will be the most likely diagnosis in this patient? So there is the hyperkalemia and there is the hyponatremia. So there is the only rare possibilities in this patient.
So I think this is something which has already been answered by Dr. Muthu, who seems to be winning this by a wide margin. Gordon syndrome. Hypernatremia, hyperkalemia, clearly we are talking about a scenario which is basically in the setting of Gordon syndrome. Now, which is the genetic defect that Dr. Manoj is now asking?
So yeah, one question is what defect can cause this kind of picture? So this is the Gordon syndrome, and why this defect has occurred due to in Gordon syndrome. So what are the genetic defects?
So it is the molecular channel which is affected. So I think if somebody had heard, Dr. Rajesh is also mentioning Gordon. So if somebody had heard Vibha, they would know exactly this is opposite to gentleman. So this is the, which channel are we talking about in Gordon syndrome?
This is sodium.
This is defect is basically WNT14 and which regulates the sodium chloride importer.
Sodium chloride importer is the defect. So what are the treatment, Dr. Manoj, in this scenario?
So yeah, for the Gordon syndrome, we have to basically manage with the thiazides. Gordon syndrome has a defect in the sodium chloride channel. The thiazide block this channel and it prevents the hypertension and it causes the sodium loss. So it prevents the hyperkalemia. So main role of the treatment is thiazide.
Okay, so carry on the next question.
So yeah, so we do have the another interesting case, which is the 6-year-old boy who presented in the ICU, basically with the tumor lysis, and her potassium is sky high, 6.3. And ECG shows a tall T wave, and patient was on AC inhibitor. So what should be the ideal first-line management strategy in this case? Should we have to stop the AC inhibitor? Second option is we need to start with the calcium gluconate. Either we should have to stop AC inhibitor with the calcium gluconate we need to start, or fourth option is furosemide. So among the four options, what is the best correct treatment strategy for this patient?
So Dr. Tolani is mentioning option C, which is very logical. Yeah. You have a child who has got a potassium which is between 6 to 7. There is already a ECG changes which are there. You have to give calcium, and you probably have to give other things like soda bicarbonate, salbutamol as well. And of course, if you don't stop ACE inhibitors, there will be a continuing problem. So Dr. Tolani is absolutely right. We have to start calcium and stop ACE inhibitors. And how does calcium work, Dr. Manoj?
Yeah, so calcium don't work to reduce the potassium, but calcium has a protective role on the cardiac stability. In this patient may presented with the tumor lysis, and there is an acute rise of potassium. So there is a high chance of the cardiac arrest. To prevent the cardiac protection, for the cardiac protection, we have to start the calcium gluconate, and the main role of the calcium gluconate for the cardiac stability rather than for hyperkalemia.
So I think that's an important point to remember. Now, what will be the next step in management of this case? I think this, of course, we've discussed that you have to basically correct the underlying cause and manage that. Now, what is the next question you're asking for?
So after that, my fourth question is, what will be the total body potassium after calcium gluconate therapy and after the insulin dextrose infusion? So in this patient, suppose if we have started with the calcium gluconate and insulin dextrose strip 2 for the hyperkalemia, so what will be the total body potassium?
So you want to know whether it will increase, decrease, or be the same. So you can give these three options. Will it increase? Will it be the same? So yes, Dr. Rajesh mentioned they will remain the same. So basically you're basically shifting the, so calcium gluconate is only protecting the heart. Whatever, even if you give insulin dextrose, you're pushing it in the cell. So total body potassium will be the same. Next question is the oral therapy option, which will be there. So Dr. Manoj, what is the oral therapy option?
So oral therapy we can give in this patient is action resin. Basically, it works. We can give via orally or by the rectal route. And what are the principle for their action? It exchange the sodium with the potassium. So it absorbs sodium and it secretes the potassium from the intestine. So these are the main oral therapy that we can use. And my sixth question is how to reduce total body potassium in this case? Because giving the calcium gluconate and insulin dextrose strip, total body potassium will be normal. So how to reduce total body potassium, which is the essential step?
So which you have already answered that you can use, and Dr. Rajesh is mentioning furosemide is a good option. That's true. You can use furosemide, you can use dialysis, you can use exchange resins and all that regards. Now the last section is rapid fire. So we will quickly have a rapid fire. So you have to answer in the chat. So the first question, Dr. Manoj, quickly.
Yeah, so these all questions we have discussed previously. So for the brush up for the revision, what are the transcellular shift of potassium? Transcellular shift of the potassium is facilitated by which transport system?
So we are looking at responses.
So you can write in quickly.
Yeah, so anybody who writes quickly will announce a winner for this one. So which is the channel which basically exchanges the potassium? I think this is very easy. So sodium potassium ATPase, Dr. Rajesh has got it. Next question.
It is perfect. So what is the treatment for the hyperkalemia in the CH? So as we discussed, there is a specific treatment for the hyperkalemia according to etiology.
So CH, what treatment will you give? That will of course
so for the CH management is different.
So of course you have to give fludrocord along with hydrocod. And remember that fludrocord requirement may be very high in the initial phase. Next question, hyperkalemia and renal failure. So
how to manage the hyperkalemia in the renal failure? So it is the very particular management.
So this is a bit confusing. I believe what you want really in that regards, Manoj.
So yeah, so for the management of the hyperkalemia in the renal failure, we have to start with the soda bicarbonate if patient is stable, and then we can shift towards the dialysis because the dialysis is the only treatment. So
ultimately dialysis will be the main treatment as Dr. Tolani is mentioning, but soda bicarbonate, because they will also have acidosis, that will also be a much more effective way to go forward. Now, this is a tricky question. So what are the formula for transtubular potassium gradient? So even if you tell me what are the things required to assess PKG, that's enough. So what measurements you will do, forget about the formula. So quickly, we of course want the urinary and the blood potassium. What else do we want? So other than urine and blood potassium, what else is required for TTKG calculation? So you are looking at urinary potassium, you are looking at serum potassium. So urinary potassium upon serum potassium divided by, you need to have the, so you are comparing potassium excretion to osmol excretion. So you need a urinary osmolality and a plasma osmolality.